Assalamu alaikum wa rahmatullah. Our session today about prostatic pathology. Prostatic parenchyma can be divided into four anatomical distinct zones: the peripheral, central, transitional, and periurethral zone. Every zone characterized by feature of specific disease. Most hyperplasia arise in the transitional zone, whereas most carcinomas originate in the peripheral zone. This diagram explains the zones of the prostate. Look this cross section. Observe the site of the prostate and the urethra pass through the prostate. Okay, the urethra pass through the prostate and the bladder. Okay, look to the right picture. This is the central zone, and this is the transitional zone, and this is the peripheral zone in the side view. The prostate is composed of numerous glandular acini which drain via ducts into the urethra. One of the secretions of these glands is prostatic specific antigen, which may be detected in the blood. This antigen is very important in diagnosis of prostatic carcinoma or prostatic hyperplasia. Elevated levels are found in prostatic carcinoma or a large or inflamed prostate. It is very important marker to the prostate. Inflammation of the prostate. There is acute bacterial prostatitis. This can occur in 2 to 5% of cases. Typically result from bacteria similar to those that cause urinary tract infection. Prostatitis sometimes follow surgical manipulation of the urethra or prostate gland, for example, urethral catheterization and so on. Clinically, like any inflammation, there is symptoms of inflammation. There is fever, chills, and dysuria. For rectal examination, the prostate is extremely tender and bulgy. The diagnosis can be established by urine culture and clinical feature. Chronic bacterial prostatitis can occur in 2 to 5% of cases. It's caused in much the same way and by the same organism as the acute prostatitis. It is generally a consequence of recurrent UTI. Patient may be asymptomatic because it is chronic inflammation. The patient may be asymptomatic or present with low back pain, dysuria, and perineal and suprapubic discomfort. Chronic pelvic pain syndrome that occur in 90 to 95% of cases, subdivided into inflammatory cases which are associated with leukocytes in the prostatic secretions and non-inflammatory cases in which leukocytes are absent. Chronic pain localized to the perineum, suprapubic area, and penis. Pain during or after ejaculation is a prominent finding in the chronic pelvic syndrome. Okay. Also, granulomatous prostatitis is a variety of chronic prostatitis probably caused by leakage of prostatic secretions into the tissue or could be autoimmune origin. From the name granulomatous prostatitis, that means in the histology, if we take a sample from the prostate, there is granuloma formation in the tissue. Fungal granulomatous prostatitis is typically seen only in immunocompromised hosts. Another pathology, benign prostatic hyperplasia, is very common in the old age of the male. Prostatic enlargement resulting from proliferation of stromal and glandular element. An important cause of urinary obstruction. The patient usually presented with urinary retention caused by excessive androgen-dependent growth of stromal and glandular element of the prostate. The most common benign prostatic disease in men older than age 50 years, dihydrotestosterone and androgen-derived major hormonal stimulus for this proliferation. Here there is proliferation, okay? Just proliferation of the stromal and glandular. Nodular hyperplasia is not considered to be a premalignant lesion. It's a benign lesion. Originates almostly exclusively in the inner aspect of the prostate gland in the transition zone. The enlarged prostate is nodular, smooth, and firm. The appearance on cut section varies depending upon whether the hyperplasia is predominantly of the glandular or fibromuscular tissue. According to that, there is differences in the histology, which the proliferation is more, either in glandular pattern or fibromuscular tissue. On microscopic examination, the nodules exhibit a variable proportion of stroma and glands. Hyper from the name, there is hyperplasia. Hyperplasia, that means there is hyperplasia in the stroma and hyperplasia in the gland. Hyperplastic glands are lined by two cell layers. This is very important. The two layer is preserved in hyperplasia, aligned by two layer, inner columnar layer and outer layer composed of flattened basal cells. This is in benign prostatic hyperplasia. This a gross above picture and left below. This is a gross feature of the prostatic hyperplasia, okay? And then the right, this is the histology. Observed, it is very rounded and appear as nodule. The glandular is preserved, but it is hyperplastic. On microscopic examination, the nodules exhibit variable proportion of stroma and glands. Hyperplastic gland are lined by two cell layer, inner columnar layer and outer layer composed of flattened basal cells, as we said. Look, very surrounded and well confirmed, well rounded benign prostatic hyperplasia, the proliferation of the glands and the stroma. This by high power, look to the two layer the glands and flattened layer, the basal layer. The two layer is preserved. Clinical feature, the presenting feature include frequency of urination, hesitancy in urination, urgency, nocturia, and poor urinary stream. Maybe there is overflow, dribbling, and dysuria also occur. Observe why this is occur, because it is in, as we said, there is acute urinary retention, symptom due to complications such as urethral obstruction. There is recurrent UTI, maybe there is hydronephrosis or even pyelonephritis. Medical treatment, we give alpha blocker, can relieve the obstruction, and 5-alpha reductase inhibitor, or surgical procedure if the hyperplasia is very abundant through transurethral resection of the prostate or abdomen. Transurethral resection of the prostate through the urethroscopy, okay? But or abdominal prostatectomy. And that is all. Thank you so much.